Welcome to today's American Community Media Weekly National Briefing. I'm Pilar Marrero, Associate Editor of ACOM and your moderator today. It took 60 years for Medicaid to expand healthcare access to over 70 million Americans with low incomes and/or disabilities. As the U.S. now faces the largest federal subsidy rollback in history, how can Americans keep the struggle for healthcare justice moving forward? And can California's fight to preserve historic expansions of Medi-Cal, its version of Medicaid, serve as the model for the rest of the country? This national briefing features a medical director at the country's largest federally qualified community health center and two veteran healthcare advocates in California and Washington, D.C. We were slated to have Joan Elker, Executive Director and founder of the Georgetown Center for Children and Families, in the panel, but she had to take care of an urgent health issue in her family. We wish her well. The speakers we do have with us today are just as great. They are Dr. Ilan Shapiro Strygler, Chief Health Correspondent and Medical Affairs Officer at AltaMed Health Services, Cary Sanders, Senior Policy Director of California Pan-Ethnic Health Network, and Anthony Wright, Executive Director of Families USA. We ask panelists to speak slowly for our interpreters in Spanish, Korean, and Mandarin. We ask reporters to enter questions in the chat. Our speakers are also encouraged to answer questions in the chat throughout the conference if they can. As usual, we will send a video, today's briefing, and expanded bios with contact information for each speaker to all participants later today. We will, as usual, proceed to Q&A immediately after each speaker presents. So we will have plenty of time for questions, so place your questions in the chat and we'll take as many of them as we can. Later this afternoon, we will send a video along with expanded bios. Our first speaker today is Dr. Ilan Shapiro Strygler, who will discuss how he's seeing at AltaMed the impact of fear on low-income and immigrant communities with rollbacks and federal data sharing, and how collective actions through groups like White Coats for Change can seize opportunities for healthcare in this crisis. Dr. Shapiro, please take the stage.
Thank you so much for the invitation. I will probably take a couple of minutes in English, and after that, do like a small abbreviated version in Spanish. My name is Ilan Shapiro. I'm a practicing community physician, and I have been working in AltaMed for the past 9 years as a Chief Health Correspondent and Medical Affairs Officer. There's moments in life, as a human, as a doctor, as a father, where everything gets connected. And one of those things is actually healthcare. We know right now that 60 years ago, with the idea of improving the outcomes of communities that needed extra help, that they were working, that they were actually left on a gap where they needed to choose between medicine and food, between actually the education of their children and taking care of their medical problems. And there was a space. There was a space there where Medicaid at that moment was one of those answers. And we can see the difference from what actually started happening 60 years ago to what's happening now. We see right now, today, as we evolve, the integration of the hope, what we actually promise our children, and most importantly, the possibility of continuing working, achieving our dreams, and giving back to society, and all of those things, because we are healthy. We have more opportunities. There's gaps, of course, but right now I'm actually extremely worried. What I have seen right now, and especially knowing that more than 75 million people actually are in touch with Medicaid, that we call it here in California Medi-Cal, and other states have different names, is that it's not just a healthcare insurance, it's a lifeline. And I'm going to give you a couple of examples of what I have seen right now. My patients before, when there was no coverage, they were using the ER as something that was the principal point of healthcare that they were using. That's not, ERs are amazing. ERs have an amazing space on our lives where they need to decide if we need to get hospitalized, they will save our lives. But it's not the best place to take care of mammograms. It's not the best place to actually talk about diabetes, high blood pressure. But what we have seen is that when we actually give the opportunity to our community members to get a hold of a physician that understands them, maybe they speak the same language, maybe they understand the same culture, but at the moment that they have primary care, it's one of the best investments that we can do. Moving it to the things that I'm seeing today, as a father, as a pediatrician, as a physician, I'm actually worried. The trickling effect of the different approaches of HR1 can actually trickle down an effect where something that we are calling it the domino effect, where we start seeing less visits to primary care, more ER visits, and of course, the waiting times will go up. The complications will go up because you're not taking care of that diabetes. You don't have the medication, you don't have your high blood pressure medications, then the complications are going to go up. Things that we can prevent, things that we have technology. It's not, it's not that weird disease that it's 1 in 1 billion people. No, no, no. It's things that we can actually make a difference. Then the cost will start going up. The direct effect that will actually happen with rural hospitals, community clinics, will be someone actually needs to start reducing opportunity services. And that means less physicians, less nurses, less healthcare for all of us. And that will have a direct impact, not only in our lives, not only in our patients, not only us as healthcare providers, but on the community. A lot of the rural hospitals and community clinics are the drivers of economical hope and achievement for a lot of our communities. At the moment that we're cutting this stuff, we're cutting not just the future of those children that also will be affected, of those pregnant women that actually will be affected, of the entire community that will be affected, but also the economical drivers that we have around us. All of these things with fear, with misinformation, with a lot of the barriers that we are seeing all around the country, will start diminishing the access of healthcare, of wellness. And from one side, we know right now that at the moment that we invest in preventive services, we are a healthier future. We have a healthier community. We have a healthier promise for our children, where at every moment, every corner, all of us have the same promise. We want to move forward. Then Medicaid is that pathway, it's that bridge where our communities can actually connect the dots. Then where are we with this? Where are we with all these questions and painful things? Because is it all gloom and doom? Well, it depends. It really depends. We know that a lot of people will actually lose healthcare coverage on the millions. And we know, for example, in California, that it's probably going to be around 2 million people, plus minus, depending on which source you actually are quoting. You already know that, there will be kids that will be out of this opportunity to being covered by a healthcare insurance. But we need to continue elevating the voices of our patients. A lot of the children that I serve have a lot of neurodivergent problems. They have chronic diseases, heart problems, things that are not just your regular asthma, but things that are actually, we need those tools. We need those evaluations. We need those resources to make sure that they continue to be healthy and continue growing. At the moment that we pull out this, the next generation of our community is going to be hindered. And imagine the example of a father that actually is working 2 or 3 jobs, but still on that bridge where he cannot get access to healthcare. And he's the bread, the one that actually brings the bread home, the one that actually is protecting the family. then if we take out his healthcare, we take out all the things that we have around us, we have a lot of problems, not just on the healthcare part, but as a society. I know that we are living hard times, but this is the moment that we need to share the stories of our patients. We need to actually elevate the voices us as providers, because I promise you, as a healthcare provider, a community physician that has been working since 2008 with every community that you can imagine across the country, we see the reality of Medicaid. It's a lifeline. It's an opportunity builder. It's a way that we can actually connect the dots. But if we do not share those stories, we don't tell what's going to happen with community clinics. Because a lot of people, even right now, they're pulling the resources for the Affordable Health Care Act. That means that a lot of people will actually, their premiums will actually go up. That actually also will reduce access to healthcare, because a lot of people will go like, well, I prefer not to have the insurance and not pay for it. And at the end of the day, we know a couple of things. We know that we are born and we need to pay taxes and we are going to die. Those are three things that we know, but we can never know when we're going to have an accident. We never know when we are going to actually have cancer. We never know when we will actually need health care. That's why it's so important to connect the dots of where we were, why this was actually created, Medicaid, where we are right now from the past 6 years. We have advanced a lot of is it perfect? No. Is it perfectible? Probably. But right now, we have access to care for a lot of millions of children. We have community clinics, community hospitals, and rural hospitals that are doing their best to continue helping the community. And also, most importantly, when we continue having a healthy community, we create a healthy future. And that ramifications of actually working, of actually studying, and of actually doing all these positive things create a wave of differences that we see. Then we need to move forward the narrative. We need to actually have the conversation of what's actually happening and why it's so important for our patients. But most importantly, be present as physicians, as nurses, as behavioral health clinicians, as dentists. We all play a big role on this,
Mm,
because we know that not because they don't have healthcare, their disease will go away,
right.
their asthma will go away, their diabetes will go away. We know they will still be seeing that. That's why today we need to celebrate what actually was built 60 years ago, what we can actually build today, and most importantly, to give the tools to our communities to continue being healthy no matter where they are. And I'm going to shift quickly to Spanish.
Doctor, your time is off, actually.
Then
Yeah,
peace out.
we have interpreters, so
Perfect.
they're doing the Spanish thing. Don't worry about it. Okay, so we have some questions for you. Araceli Martinez from La Opinión, do you want to ask your questions?
Hello, doctor. Mucho gusto en verlo. Can you give us more specifics on how these cuts will affect immigrants with immigration status, especially in this moment that we are living, that the cost of living has skyrocketed, and if we have some numbers about how many Latinos could be impacted in California. Gracias.
Araceli, as always, a pleasure to hear from you and see at least your name on the screen. One of the things that I can actually share on the medical aspect of it is that there's fear. And when there's fear, there's actually lack of trust. And knowing that, you're in survival mode, the most important thing that you have in front of you is actually taking care of your family and yourself. Then healthcare and wellness actually starts driving downwards right now that we're in survival mode. And that means that a lot of people will choose and are choosing not to take care of the wellness part of it, take care of their diabetes, take care of or their high blood pressure, or even approach ER emergencies. Then we will start seeing more complications. We will start seeing that part. We'd love to actually deep dive and about the numbers. We can actually take it offline afterwards. But right now, the thing that I'm feeling and perceiving and hearing, it's that fear is driving people to choose to just go to the survival mode instead of actually doing, well, I still need to take care of my diabetes, my asthma, my other things. Then we probably will start seeing more chronic diseases. I'm afraid, for example, what will happen in influenza season, at the end of the year, where a lot of people will probably get influenza, and usually they will go to ER, urgent care, your doctor, and we'll start seeing probably more complications and ER visits on that one.
Mm, yeah. Okay, we have Hung Duan. Do you want to ask your question, Hung?
Uh, yeah, hi. My
Hi.
question is, in California, what which community you think that will affect most on the cutting from Medicaid from the government? Or the immigrant is the most, or Latino is the most, or Asian is the most? Thank you.
Mr. Huang Don, thank you so much for your question. The cuts are going to hit every community that they do not, like, and we can go by percentage of which population we have more here in California. But at the moment that you do this type of cuts, you're hurting people that are coming from different places, that they are here and doing they're here and actually accessing healthcare. Then at the moment that we do these cuts, it's not prescribed for a specific group, but there will be probably a big number that will start seeing that, what was actually the normal before, it's not anymore.
There's a question from Elena Kuznetsova. You want to ask your questions, Elena? Your question, sorry.
Yeah, thank you, Pilar. I have two questions in hopefully I'll be able to get some answers. So are there any state programs, resources to support those people who will most probably lose their Medi-Cal? It's first question. And the second one is in case of Medi-Cal coverage is lost, what are step-by-step instructions for the people so that they could get medical help for reasonable cost and not to feel robbed? Thank you.
Elena, thank you so much. I'm going to address the second question first. At the moment, and this section, it's not even just for now and the system that we have right now, but it's always. There are a lot of community clinics. There are also a lot of spaces that will actually be and render healthcare as needed on a very reasonable price. Then that's across the state, across actually different states. Then, there's always a place where people can have access for that. It's kind of the safety net that has been built. Sometimes the problem is that, you can actually get the first round, like if you have an infection, you have like high blood pressure, diabetes, all that stuff can actually be managed. It gets more complicated when we're talking about surgeries, when we are talking about cancer treatment or other advanced medical needs. Then on that part, that depending on the state, you will have different groups that can actually help achieve that. I would recommend there's a group called NAC, is the National Association of Community Healthcare Clinics. They actually have a robust list of resources for that type of things. And that's kind of the most important thing that I hope that I answer and you can share with your community.
And if you can put the name of that organization in the chat, Doctor, will be helpful for people. Thank you so much. We're going to move on to our next speaker now. And our next speaker is Cary Sanders, who will give a state-level view of politicians and advocates' efforts to protect California from federal Medicaid setbacks. Welcome, Cary.
Welcome. Thank you so much. Cary Sanders with the California Pan-Ethnic Health Network. CPAN was founded in 1992 on the heels of the police beating of Rodney King in Los Angeles. And Our call to action was to bring together communities of color to break down divisions and build a movement of racial solidarity united behind a vision of universal health care that includes the right to live in healthy, safe, and dignified communities. This year is the 60th anniversary of Medicaid. I appreciate the title of this webinar. And for folks who may not know, Medicaid came into existence 60 years ago as a civil rights era program to ensure that the government provided basic health care to poor people. It was passed fairly quietly alongside the creation of Medicare and the passage of the Voting Rights Act and the Civil Rights Act. And despite assumptions that it would be a temporary program, it's still here. It has beat the odds. This is important, this history, because of the interconnection now between the attack on Medicaid and the attack on our civil rights. And this is not a coincidence. As much as Medi-Cal or Medicaid is a healthcare program, it's also an anti-poverty program. And it's foundational to our ability to advance health and racial equity. Healthcare is very expensive and a key driver of personal bankruptcy, particularly in a state like California where the cost of living is so high. And Medicaid has really allowed families to inoculate them from poverty, redistribute resources, and to be able to live healthy lives. The Medicaid expansions in the ACA were optional, and there's a reason. And many states, that chose not to provide those expansions have seen, much higher rates of inequities in communities of color. But California is not one of those states. We understood the assignment. We expanded the ACA. We've never looked back. And in fact, I know Anthony's going to be joining us, but when I started at CPEN in 2009, I was right before the passage of the ACA and had the privilege of working with Anthony and Health Access with CPEN as we tried to pass our own universal health care and coverage. When that failed, we worked to pass the ACA, and then we spent years implementing and building upon it. And California went further, as did many other states. We expanded healthcare to all Californians, regardless of immigration status. We brought down premium costs in our state marketplace and zeroed out copays for our lowest income Californians. We also codified stronger consumer protections into law. So insurers can no longer consider things like pre-existing conditions or offer to sell junk insurance that's cheap, but really provides no comprehensive coverage. Now as we look at some of the provisions that Dr. Shapiro mentioned, we understand that, in this one big beautiful bill, we know that, this is an attack on states that have really gone further. In terms of the bill restricting access to the ACA for immigrant communities, including those lawfully present, such as VAWA recipients, refugees, asylees, but it also imposes work reporting requirements that target low-wage workers, largely people of color, with onerous paperwork requirements that will knock them off of coverage. And as well as by offering states to not take up the ACA expansion. But you asked me to talk about whether we should feel hopeless, and if not, why not? Of course, there's no sugarcoating the harms of these provisions, but states also have flexibility in how they implement these new provisions in order to try to mitigate some of the harms. And California, like many other states, is looking for ways to do this. And Anthony can talk about this too, but in ways that will try, be as beneficial as possible or mitigate some of the barriers to the extent that we can. A couple examples when we talk about work requirements, states are looking at, how can we automate reporting in order to lower the burden on individuals? How can we leverage lessons and learnings from other states that have implemented work requirements, which frankly have largely failed. But what are some of those lessons that we can apply in our own state to keep people covered? When we look at CalFresh recipients, for example, or SNAP recipients, many have had many able-bodied adults, already have to document community engagement and other requirements. What are some of the learnings? What databases exist and how can we leverage those? Secondly, and that's just, work requirements. There are other things we can do potentially in terms of co-pays, how to respond to immigrant eligibility restrictions. Even with those federal restrictions, states have the option to cover these populations with their own dollars. A much heavier lift, but there may be creative ways to think about how we keep these communities whole. Secondly, and sort of my last or a second bullet is really around accountability. Californians now recognize healthcare as a fundamental right. The ACA has really allowed our uninsurance rates to go down to where we are at 6%. We're 6 percentage points away today from achieving universal coverage. And we're not the only state that has, really moved this trend and begun to focus on, as Dr. Shapiro mentioned, how can we actually eliminate health disparities through investing. When we invest appropriately in healthcare, what can we do to ensure that everyone leads to better outcomes? And so this is our starting point. We don't want to go back. We need to hold those who voted for this awful bill accountable, no matter how people try to, I'm not sure why my volume's lower, but no matter how people try to sell this bill, the more people know about it, the less popular it is. And so we really need to continue to voice and educate about what this means. Secondly, thirdly, we need to talk about revenues. States will still be able to, and I know there are some questions, states will still be able to receive federal funds for emergency services. State marketplaces are looking at ways that they can help to backfill potentially some of the loss of premium tax credit subsidies that may not be extended. But the fact is that medical debt is going to be a problem, and we really can't shy away from having difficult or controversial conversations about the cost of care and ways to both bring down the cost of care, whether it's through revenues or also really leaning into and taking advantage of the types of financial assistance and charity care policies that can help people who have high medical bills get insurance coverage that they need. Thanks.
Thank you, Cary. I don't know if it happened on their side, but suddenly the volume just went down, way down. Do you know why? No? Okay, just check, just in case. Just check, just in case. Okay. All right. We got an email, a question by email that I think it's very relevant, and it's a very broad question, but we are celebrating 60 years of Medicare, and there was a lot done during those 60 years to expand coverage with so many changes, with this new bill cutting so much money from Medicaid. How much are we at risk of losing the progress we made for our communities during this time? What is the size of the setback? Just put it in context for us.
Yeah, that's a great question. Nationally, it's an enormous sum of money, and many millions of people are going to lose access to healthcare coverage unless changes are made, and that there's no way to really sugarcoat that. This bill, this monstrosity of a bill, really will weaken our Medicaid program and make healthcare much less affordable for millions of people across the country. You know, I can't really sugarcoat that. And we do have time, in the sense that a lot of the changes don't all happen right away. And so this is why this education piece is so important. We have an opportunity now, and we must continue to educate and let people know what was in this big piece of legislation that just passed, and hope to change it.
Yeah, there needs to be a lot of education for sure. Let's see, there's a lot of questions here. Let's see. Pamela and Chang has an interesting question about what grassroots groups and others, including ethnic media, what can we all do? Pamela, do you want to ask your question?
Sure. Can you hear me?
Yeah.
Okay. So my question is just basically, I guess to apply to all the speakers. Immigrants are right now in the shadows, they're hiding because of the raids. And of course, what that means is that children as well, born to these immigrant families, are not getting care, even if they can. And then also, most of you have stated that there's maybe like a sliding scale. There are immigrants who cannot even afford even the sliding scale, even the smallest payments. So are there any resources in place to mitigate that? And for the hard to reach populations, for the parents who are afraid to go and see the doctors, are there any resources in place also to take care of that? Such as, I remember during COVID, there were what they call those virtual consultations and stuff like that. Are there any resources beyond that to help mitigate this crucial situation?
What can you tell us, Cary?
Oh, I was gonna say, I don't know if Dr. Shapiro wanted to talk about that a little bit. I think a couple things. So, I will just say, so it's hard because I have a California perspective here. In California, we are still providing coverage for for immigrants with unsatisfactory immigration status, although it will be restricted coverage. So different than full scope. But there will be some options for families. Undocumented adults, it will be a different story, but they will still be able to should still be able to access emergency medical care. That said, one thing that I was explaining as well is, we actually have a hospital charity care and community benefits laws that require hospitals, if someone uses healthcare and has, a big expense, but they're uninsured or they're underinsured, they may be eligible for financial assistance. And so, part of our work, will also be really to make sure that people are aware of this financial assistance, and that hospitals are proactively screening people who may not have access to healthcare now due to some of these changes, to ensure that they're getting the financial assistance that they need. And I'll let Dr. Shapiro, I don't know if you want to add.
Love, Cary, your answer, because I think that you mentioned absolutely everything that we need to know. And I will add something that is actually from Mr. Akurt, asking me, if Medicaid goes away, what else can we do as a community? One of the things that we need to be doing is making sure that we talk about prevention. The things that we can do to create resiliency in two sectors are extremely important. One is actually the healthcare part of it, talking about, we need to eat differently. We need to actually move, do exercise. We need to figure out a way that our stress levels, that we all know that it's a reality, that stress is part of our lives. But now that we are all in survival mode, that actually takes in a different level. It creates a lot of chronic diseases. And how can we all of us as a society start messaging the correct hope for this part. Let's move in family. Yes, we're stuck in the same place and we cannot go out, but we can still do exercise at home. We can still meditate. We can do. There's a lot of other resources that even if everything fails, we can still help the family and the community in the meantime to try to maintain all of us as healthy as possible.
Thank you, Dr. Shapiro. We will move on to our third speaker, and that is Anthony Wright, who before heading Families USA in Washington, D.C., was executive director of Health Access California, where many times we consulted him on issues relevant to health access. Mr. Wright will draw on his experience as a policy strategist to discuss how we can advance healthcare justice through strategies counteracting these historic Medicaid cutbacks on a national level. Welcome, Anthony. Anthony, can you hear us?
Can you hear me
Yes, now I can hear you.
and see me? Okay, great.
Okay.
Sorry, I'm on a train. Thank you for your accommodation for me as I am doing this from a train, but I really appreciate being on. Great to see great colleagues like yourself, Pilar, like Cary Sanders and CPEN, like Dr. The good doctor, and many people on this call. As folks know, I for the last 20 years was the head of Health Access California. Now I'm in this new role at Families USA, working nationally on the goal of healthcare. And I'll just say a few quick things and really want to get to the questions. But, number one, this was a disastrous bill that just passed, that it is a major setback to healthcare, to health coverage, and to health costs. That the estimates are that over 15, 16, 17 million people will lose coverage as a result, either because they are pushed or priced out of coverage, largely through bureaucratic barriers, but also through increased costs. Those costs are significant, whether they be in public or private plans, whether in Medicaid or the marketplaces. Places like, so we're going to see both increased cost sharing in Medicaid, up to $35 for a doctor's visit, but also increased premiums in the marketplaces, both because of the expiration of some key tax credits at the end of this year, but also because as you push people out of coverage, that leaves a smaller and sicker risk pool, which means that the premiums have to go up to cover that on average sicker population. And then just the cuts to care, that at the end of the day, this is a cut to the hospitals and clinics and other healthcare providers and the state government, which then will have to make some tough choices about what it cuts, whether it cuts people, whether it cuts benefits, or whether it cuts rates to providers. And so any of the key institutions that we rely on, especially those that rely on Medicaid a lot, that where Medicaid is the primary payer, the biggest line item in the budget sheet. And that's things like maternity wards, since a majority of births in California, near a majority nationally, are Medicaid, are paid for by Medicaid. So maternity wards will be particularly hard hit. Nursing homes, community clinics, we talked about that already. The just a range of services. If rural hospitals, this will be a cut that will impact them, and they will have to scale back services or close altogether. So that's the bad news. The question that I was given was, what do we do now? And I think the question that I would offer is, how do we? I would say three things to pay attention to. Number one, we need to make people accountable for this vote. There's all these bad consequences: rising premiums, people losing coverage, services being scaled back or closed. We need to make sure that people connect the dots back to this bill, because the issue is, if they don't realize that, then they'll come back for additional cuts. There are people in DC who wish to have another budget bill to do further cuts, to do the cuts that we were able to prevent on some of the fundamental formulas of the Medicaid program. There needs to be continued federal advocacy, both against those efforts and just even this fall. I mentioned that these tax credits are expiring at the end of the year. So there is now in this bill, the members of Congress voted to extend tax cuts for the wealthy and corporations, trillions of tax cuts for them, but they neglected to extend the tax credits that help people afford healthcare. So, however, there is one last best chance to do that, and that is this fall on September 30th, when they have to fund the extension of the government. So there's one last chance, and members of Congress need to hear from their constituents that they don't want to see the premiums spiking, where if these premiums are not extended, then the average person in the marketplace will see a 75% increase in their premiums. Many will see their premiums double. Many people, especially older folks, will see premium increases of hundreds, if not thousands of dollars. And so this is something that needs to be dealt with directly. And needs to happen literally. This is not for like in the next year. This is the next month, and so that's a concrete thing to take action of. And then finally, but then I would say, as much as I and my work at the national level is very important, I think it's even more important now because the work now doesn't stop; it explodes in 50 states at state capitals, including in Sacramento, where states are going to have to make some very tough choices. But even though the bill does some bad things, states do have choices about what they do. They can decide whether they um, implement these cuts and make awful decisions or whether they raise their own revenues. They can decide whether they're going to have a harsh version of these bills, of these bureaucratic barriers, of these reporting requirements, of these semi-annual status reports, etc., or whether they try to make it as easy as possible, even with the constrictions of the federal government, whether that is things like making things easy to sign up for electronically, using AI tools, using efforts to do whatever we can do to try to make it easier so not as many people fall off. I think the decisions at the federal level, at the state level, is probably the difference between several million, plus or minus several million people keeping or losing coverage as a result of what happens at the state level. So that is the work that needs to happen right now. So anyway, and then the final thing I just want to say, and then I want to take it to questions, is that we should be clear, and I apologize for the announcements behind me, but we should be clear that at the end of the day, some of our work is to undo the damage, but we recognize that the system wasn't great beforehand, that it was that in many ways it was a system that failed many people. And so we want to, when we're working on the plan, we need to undo a lot of damage, but we also need to put forward a vision for a better, improved system for all. And that's a system that is affordable, that is accessible, and is also administratively simple and if not automatic. And we took several steps backwards with this bill, but I think that maybe that then brings a broader constituency, a broader organizing base for people to be pushed back for a anti-paperwork agenda of how do we get a system where there is not so all these bureaucratic barriers for everything, for getting care, for getting coverage. And I think that's part of the work that we need to do going forward. And so with that, I'll stop and happy to take questions.
I'm so sorry, I was muted. There's a lot of questions, but let's see. One of them touches on the issue of accountability for the people that voted for this bill. This was I believe, a party line vote, right? I mean, this was a vote by Republicans to support Donald Trump and what he wanted to do. How do we make politicians accountable? I mean, yes, we know we have to vote. And if we vote next year and we make Democrats the majority in the House, for example, even in the Senate, maybe, that's more difficult, but in the House, can they undo what has been done in this bill?
Yeah, I mean, I want to both. This is all undoable. This is all changeable. I want to be honest that a change next year will probably change one house of Congress, probably not both. But even if you do both, you still have a president in power who may veto things. So this is
Yeah.
not a 1 year project or a 2 year project. This is a 4 or 5 year project, a decade-long project. But I also remember, and Cary was revoking this earlier, when I came to Health Access California, there was about a decade of, bad budgets and, and failed efforts in health reform before we finally got the punch through with the Affordable Care Act. It was able to take California from one of the states with the worst uninsured rates and have the biggest drop of the uninsured rate of all 50 states. But so sometimes change takes time, and that's the work that we have to engage in over the next several years. But so this is a longer fight, but it starts literally with the fight around the expiration of the tax credits in the next month.
Okay. All right. Okay. I'm gonna invite in everyone else, all the other panelists, to chime in if they want on more questions that we have here. We have a question. I'm gonna read them instead of having them read them. From Jennifer Liu: beyond preserving current expansions, what long-term reforms are needed to make Medicaid more resilient against political and economic shifts? That's a good one. Anyone? Maybe Anthony or any of the others.
I mean, I think part of this is politically resilient, which is doing the organizing and making sure that there's a constituency of people who care about Medicaid, who care about health coverage, um, and who will defend it. But part of it is fiscally resilient with regard to making sure that we have the financing mechanisms, and that's supporting, frankly, taxes and revenues at the local and state level, as well as the broader tax and better tax policy at the federal level, where we're not giving tax breaks to wealthy corporations, but we're funding the programs that help everybody, including the wealthy, but everybody else as well.
And there's another question here from Rebecca Bartus. With ICE officials,
Pilar, sorry, if you don't mind, I'm going to take a quick stab on that one.
Sure. Okay.
And following Anthony's lead, the other thing that we need to make sure that it's real is the economical impact of actually what means the money that we're saving with Medicaid. And we have seen, compared to other systems, where we know that it's not perfect. And yes, there could be some problems and we can improve it. But if you actually put Medicaid and also the community clinics, and we actually are saving around like $1,000 to $2,000 per year on that patient, then it's cost effective. It's not only helping our community, but it's also saving us money. And that's just one part of it. We need to add that we're working more. We're taking care of our families. We have the possibility of taking care of all the preventive services that are not accumulating with chronic diseases. And also, very importantly, the resiliency of telehealth and technologies will be very important, because that's a great connection that we have seen since COVID-19 until now, where a lot of our patients can still go with their doctor, take care of themselves wherever they are, and also, continue working and having another opportunity for them. Thank you.
All right, thank you. Thank you, Dr. Shapiro. So we come to the issue of privacy. Rebecca was referring to the access to personal data of Medicaid recipients. How can healthcare networks and immigrant advocacy groups rebuild trust in immigrant communities to ensure they can access care without fear? Well, that's a tall order. What do you guys think? We're losing trust as we speak.
Yeah, it's a great question. I think, and Dr. Shapiro touched on this. There is absolutely a chilling effect. The fact that, personal information, we now know that this is confirmed, including people's addresses, their enrollment status, etc., is being shared with the Department of Homeland Security. It's a travesty. This is illegal. It shouldn't, just be clear, this is a violation of a long-standing agreement and pact that this data would not be shared. But the fact that it's real, and it is having a chilling effect. There are a couple, I think, what I would say, maybe silver linings. We work very closely with community health workers, promotores, and representatives. They are still in their communities, just as, Dr. Shapiro and clinics and other folks, making sure that people are, getting educated, that people are aware, for example, that you can provide some of these health services through telehealth. If folks are afraid to go into the clinic, they can see a doctor, through those means. There are other creative ways that providers, are really trying to address these problems, whether it's a community health worker or a doctor or clinics, mobile crisis, mobile clinics, other types of, places where folks can go to get access to healthcare services where they feel a little bit more secure. And so, those are the kinds of creative solutions that, that the health systems will need to come up with, and that we may, be seeing more of in other parts of the state of the country as well.
I wanted to ask you all about the impact beyond Medicaid. Anthony referred to the increases that people getting care through Obamacare will have because of the money that they get from the federal government to pay for the prime is going to go down. What about Medicare? I know there's going to be an impact on Medicare, which is the older adult care, and that usually works together with Medicaid with older adults are poor. What are the impacts there?
I think that's a great question. The bill did, in its construction, trigger a $500 billion cut to Medicare. The majority says that they're going to undo that, but that is what they did. And if nothing is done, there will be a triggering of cuts that will actually have an impact on payment rates in the Medicare program as well. But even if they do undo that, Pilar, I think you're exactly right. People don't recognize how interwoven Medicaid and Medicare are. There's many people who, Medicare, there's many people who are quote unquote dual eligibles or Medis who are on both, because Medicare doesn't actually cover, has big gaps. And for people who are at certain incomes, which are a lot of seniors, Medicaid fills in those gaps in really important ways. And then I guess the other thing I would just simply say is that the scale of this cut, we have to remember, this is the biggest cut in the history of Medicaid in history. And when you make a cut of this size, it doesn't get contained in just one area or one population. If the cut is to the hospital or to the clinic, it affects everybody to that, regardless of who you have the Medicaid.
I can see that train is moving, so because we're losing you.
I think I can finish Anthony's comment,
Yes.
and then he could jump back in. But I think he's just saying that cut is not just to the individual; it's to the entire systems that get payment for providing these services. So this is it has a much bigger impact. It's not just an individual, but it's an entire health system that is funded, that provides jobs, frankly, for doctors and providers and clinics in rural areas, rural parts of the country and rural parts of the state. Dr. Shapiro talked about that too. Those clinics are going to be at risk. And it's not going to be just the folks on Medi-Cal who are going to be, who are going to have problems finding healthcare. These are, few and far between options for folks who really need healthcare coverage.
And adding to that part is that you need to think that most of the community clinics and rural hospitals or urban clinic hospitals also hire from the community. It's one of the most stable, amazing places when you can actually grow and be part of healthcare system where the job security, the thing that it means for you and your family and your community has been a pillar for growth for those communities. Then apart from actually traveling 2 hours away to actually have a pregnancy that it's high risk that we are seeing it right now and it's going to get worse, apart from actually having a heart attack and driving 1.5 hours to the closest hospitals that they can take care of my heart, also that can happen here in an urban setting and the ramifications of everything that will close around it. It's not it's healthcare, it's economics, but it's also the community that will be hurt. Then this is and I love how Ms. Sanders actually mentioned this, that it's everything is connected. It's not just healthcare, it's our lifeline.
Okay. We don't have a lot of time left, but Sunita, go ahead and ask your question.
Thank you, Pilar. And for any of the speakers, can states raise revenues to backfill some of the federal cuts? And does the One Big Beautiful Bill specifically prohibit this from happening?
Do we know? Is Anthony still on, or is he gone on Amtrak?
I think he's still here, and I'm sure he can jump in. But yes, I mean, it's a sort of a yes and, right? Like, this is, for California alone, that we estimate a loss of, or our governor estimates a loss of $30 billion.
That a handful of.
Oh, are you jumping in, Anthony? Go for it.
Go ahead, Cary. Yeah.
Oh, just saying that in California alone, the governor estimates a loss of $30 billion annually in dollars to California. We cannot raise our way, out of that. However, that doesn't mean that we can't try to come up with other, options, other ways to at least raise some revenue to close some of those gaps. And so, I think others have started talking about this, but we need to really look at cost drivers, how we can bring cost drivers down. But also, for example, we know that we need to close like corporate loopholes. We know that, large employers, for example, many large employers don't provide healthcare for their workers. And so their workers are actually on our Medi-Cal program. Maybe now, in this moment where we have so much to lose in terms of, the federal funds and dollars, it's a time to really look at, making sure that everybody's paying their fair share, that employers are part of the system if they're not, that, hospital, profits are going back into, financial assistance or to community where they can. So really just looking at all of these different potential ways to try to, at least raise some dollars. Yeah, I don't know, Anthony, if you want to add.
Let's just go to, I want to ask something of Dr. Shapiro. Dr. Shapiro, you founded an organization called White Coats for Change. Can you quickly, because we're running out of time, tell us what it is?
In general terms, the most important thing that we have right now is to understand and be part of the conversation. And when we are healthcare providers, that means nurses, doctors, dentists, behavioral health clinicians, it's extremely important to make sure that we have that conversation and we share the stories of our communities. Then practically it's actually empowering and having conversations with the physicians and also with our patients and telling the story. A lot of the times, we just see the numbers, but actually putting a face in a concrete action and sharing that story with community members, with NGOs, with our people around us can actually have a lot of impact for hope, for resources, and of course, to create a better system for our community.
Well, thank you, everyone. We ran out of time, but there is so much on this issue. Thank you so much for being with us, for sharing your expertise and your time. And please come back to us when we have another opportunity like this. Thank you to report.